we should be able to do at the end some clinical demonstration of some tests that we use clinically when physicians actually touch patients nowadays, which is getting rarer and rarer, doing a physical examination. So I think it's always good to know about the anatomy. The spine is really divided into several sections. The cervical spine is the neck area, the thoracic spine. It used to be called the dorsal spine, which is a misnomer now. In the original Gray's Anatomy considered it the dorsal spine, but the dorsum is actually the entire back. The thoracic would be the correct terminology, and the lumbar spine, and then you have the sacral area, and in between them, quite obviously, you have your disc spaces. What's interesting is actually they're not spaces. They're obviously filled with gelatinous material, and we'll go over what that is. And the reason that you don't have a solid bone in the spine is that, well, how would you bend? So it's very important that we have the disc spaces in between the vertebral bodies because they allow motion in the cervical spine. What would happen if you did not have disc spaces? Suppose it was solid bone. There actually is a condition, it's called ankylosing spondylitis or Maurice-Strump disease, in which all the disc spaces actually become calcified, and people don't have any motion. They essentially have a fused spine. Early in my practice, many years ago, I actually had a workers' compensation case about someone who had ankylosing spondylitis, and they had a fused spine, and they actually broke their back in the mid portion. If your entire back is fused, it becomes almost like the femur bone, and then if you have an injury, it generally is a crack in the middle, and that's exactly what it was, a crack in the middle of this solid mass of bone. And then I was new in practice, and I had to figure out what to do, so naturally there wasn't the internet then, so you call up a traumatologist, and there was a fellow out in Seattle who said it's very hard to get it to fuse because of the motion that always occurs at the fracture site, but he came up with these things called Weiss springs. And Weiss springs were like the springs that close your screen door. And they had little hooks on them, and what you did is you went into where the fracture was and actually hooked these in on each side, and they would provide dynamic compression, and then you would bone graft it, of course. So I did this because I was a kid, and I bone grafted, and somehow or another I got it to heal. And I don't know how it healed. And then I said, well, this is a great case to show. And I made the wrong decision to brag about it. And ever since then, I've never bragged about anything because I showed the case, everybody looked at it, and then for the next year, all I got was every failed back surgery was sent to me because now I was the expert on doing back fusions. So I learned early in life that's probably not that great an idea to brag about things, but it did work. So the anatomy of the spine is interesting, and it is, again, vertebral bodies with disc spaces. The cervical spine is extremely interesting because, I guess we'll go here and use that there are 7 vertebrae. The head weighs about 10 to 12 pounds, so the cervical spine supports that. And the C1 vertebrae is known as the atlas, and the C2 vertebrae is known as the axis. And there is also another articulation, which we'll talk about in the next slide, which is really where the head sits on the atlas, where the occiput of your skull fits into these facets, and that gives you the ability to nod. Like if you just hold your neck steady, I'm holding my cervical spine steady and I can go up and down. That actually is motion at the occipital atlantal joint, which is on top of the cervical spine. So that allows you to nod. And your rotation of your neck, the ability to go like that, predominantly is at the C1, C2 area. So, and what it does is this dens, the odontoid, is basically a pivot point, and this actually fits inside the atlas. And this is also held in place with, we don't have it on here, but it's called the transverse ligament, which holds everything in place. And the reason that's important in trauma is that there are many conditions where you have ligament laxity or ligament damage. One of them would be rheumatoid arthritis. People with rheumatoid arthritis, if you ever see the people with rheumatoid arthritis, they have disfigured fingers because of the imbalances and ligament problems. And many people with rheumatoid arthritis will actually have an incompetent transverse ligament. which could lead to atlas axis instability. So if you have a patient that has rheumatoid arthritis and you're going to be putting them to sleep and using general anesthesia, it's not all that bad an idea to take flexion and extension films, have the head all the way down and all the way back, and then you can see the interval here and to see if it widens out, because you don't want to have any instability, the risk of doing damage during anesthesia. If you go ahead and put someone to sleep and they have increased instability here, then you're going to get spinal cord compression at a very, very bad area. So it's not uncommon to have fractures in this area, and many of these fractures need internal fixation. Anyway, the rest of the cervical spine is pretty, from C3 to C7 is pretty standard, and what you have is basically you have your vertebral body, and we'll go over the lumbar spine as well. Then you have the area where the spinal cord passes, and you have your various facets. The foramina, as we'll talk about, the foramina are the spaces between the vertebra bodies, and that is where the nerve roots exit. So when you hear the term foraminal encroachment, what that means is that the nerve roots are being encroached where they go out from the central canal. The atlanto-occipital injuries are found in motor vehicular accidents, and interestingly, it only represents 1% of cervical spine injuries in the acute care setting, because most people do not survive an atlanto-occipital dislocation where actually the head becomes separated from the cervical spine. But it's very common in autopsy in accident victims. And it represents a lot of trauma, obviously extension, flexion and extension, large accelerations as I put out, falls from heights. What you can see here, if you look at a normal lateral view, here's the skull and here's the first, here's your atlas, the first cervical vertebrae, and you can see over here the huge separation between the skull and here. And this is actually where the head becomes separated from the cervical spine. Obviously, it can be associated with brain injury, and talk about brain injury, that sometimes the diagnosis gets missed because you have such a deficit from the brain injury that you have to be on the suspicion for an atlanto-occipital dislocation. These were somewhat hard to, sometimes with x-rays and all that, to delineate, but with CAT scans now, the diagnosis is a little bit easier in people that survive this. And most of the time, if you have an atlanto-occipital dislocation, then surgery is going to be required. The thoracic vertebrae are interesting because you have 12 thoracic vertebrae, and the only difference is that they have an area where the ribs attach. And the reason is the ribs need to be attached, and what happens with the ribs are it gives stability to the thoracic spine. So you have 12 thoracic vertebrae where the ribs attach. Somewhat interestingly, there are things called cervical ribs, and cervical ribs are where there is an additional rib that attaches to the C7 vertebral above it. And sometimes these can be associated with what you're called, thoracic outlet syndrome, where you have a cervical rib. A cervical rib is a developmental abnormality and may put pressure on the artery or brachial plexus. A lot of these are just found incidentally, but if you do have a cervical rib, that could be implicated in trauma, vehicular trauma, so that has to be looked for. Interestingly, from my research, if you have a child with a cervical rib, there's a higher incidence of leukemia in children that have a cervical rib. This is one of these statistical abnormalities that people should know about. And again, the internet is full of good things, but with the decline of the woolly mammoth actually developed a cervical rib from inbreeding, and it was theorized that part of the species elimination might have been due to blood dyscrasias or leukemia, which actually killed the woolly mammoth. So all these things are very interesting. The answer is that when you have a developmental abnormality, as an orthopedic surgeon, when you see children that have an abnormality, a scoliosis, or they have something that isn't quite right, you've got to look for another abnormality because you might be missing something. So that's something that the pediatric orthopedics are aware of. Thoracic vertebrae have very few disc herniations, and the reason for that is because of the stability of the thoracic spine. But a lot of times what happens is rotation. Now, I'm a terrible golfer, but a good golfer basically is rotation, and that's why it's the rotation that gives you power. That's why, if you ever notice, the bigger golfers don't necessarily hit it further than smaller golfers, because it all depends upon rotation of your thoracic spine. When they say go shoulder to shoulder, it isn't your shoulders that are moving, it's actually your thoracic spine. So there's tremendous torque applied to the thoracic spine. So golfers have a higher incidence of thoracic disc herniations because of the twisting motion. You really don't get the flexion and extension in the thoracic area. Thoracic disc herniations are visible here on the MRI. This is at T2 and T3, but usually at their a little bit lower levels. And what happens is that these get missed. And the problem being is that the spinal canal in the thoracic area is relatively small. So you can have a disc herniation that isn't that large, but it's going to impinge in the spinal canal. So it's very important that this diagnosis be picked up. But it's like anything else. People come in complaining of chest pain. And you know, chest pain could be a million things. And a lot of times people are thinking about heart attacks, GI problems and all that, and they forget about a thoracic disc herniation. So what you have to do is you have to actually touch someone and do a physical examination. People can sometimes come in. We saw someone come in with a gait abnormality because the herniation was so big. They had a myelopathy of the spinal cord, so they came in with a gait abnormality. They can have paralysis of the abdominal muscles, and there are ways of testing for the abdominal muscles when you do a physical examination. And they can have bowel and bladder problems. But the diagnosis of an acute thoracic disc herniation coming from and it usually is related to trauma, although people can't always remember how it happened. But if you have someone come in the emergency room with chest pain, radiation pain, radicular pain, which could be the nerve root in the thoracic area coming around your chest, people coming in with other neurologic symptoms, you must consider a thoracic disc herniation. Diagnosis now is a lot easier with the MRI. The old days you'd have to subject someone to a myelogram, which wasn't a lot of fun, but with the MRI this diagnosis is made. The point being, if they have neurologic symptomatology, then they need surgery right away. They need to have the area decompressed. If it's missed, then you can have permanent problems. So the diagnosis has to be made. The other problem comes in, it's very difficult surgery. The original surgery was done posteriorly, like you would do a laminectomy and disc excision in the lumbar spine. Unfortunately, the spinal cord in the thoracic area is very susceptible to retraction, and you have to retract in order to get out the disc herniation. So a lot of people are recommending now that you can go in actually through a microscopic transthoracic approach with a thoracic surgeon and then go in there and remove the disc material. So sometimes the cure can be worse than the disease. You got to know what you're doing. These are specialized cases and have to be done at specialized institutions. Going back to where we see most of the problems, the lumbar vertebrae. The lumbar vertebrae are much bigger, and the vertebral bodies are bigger simply because they support the weight of the body. As you go down, the body's obviously heavier, so it has to support the weight of the trunk. So the vertebral bodies are bigger. You have the frame, and this is where the spinal cord goes through. Transverse processes are where muscles and ligaments attach. And you have your articular processes. We'll go over that. But what you're seeing here on the side view is you have the vertebral body, and where it joins with the next vertebral body, you have this hole, and this is the foramina. And the reason that you have the intervertebral foramen is that this is where the nerve roots have to come out. So the nerve roots exit through the foramina, which are really holes formed by the junction of one vertebrae on top of the other vertebrae. So when the stuff comes out of here, when the nerve roots come out, you can see they can get pinched by a couple of things. We'll go over it. We have additional slides. But if you have the disc herniation, if there's disc material coming out, it'll pinch this nerve root. If you have spurs or you have articular facet arthritis, it can pinch the nerve root. So foraminal encroachment can come from a number of conditions, but that's what that term means. And then, of course, you have your disc spaces. When you do get a herniation or encroachment and you have irritation of the nerve root, that's what is commonly referred to as sciatica. Sciatica is pain that goes down your entire leg. That's true sciatic pain is pain that goes down into the calf and usually into the foot. It does not refer to pain going down to the knee. It's commonly mistaken. And the way they know that is because the studies were done in the past where medical students, of course, were injected into the low back area, into the muscles and ligaments. And they would get radicular pain that would shoot down to the knee because of the innervation of the soft tissue. So just because you have back radiation into your buttock and down your leg is not truly sciatic pain unless it really goes down into the calf, and then more specifically it goes into the foot. So back pain radiating down to the knee does not necessarily have to be a quote sciatica. The reason it's called sciatica is because the lower lumbar vertebrae, the lower lumbar nerve roots form the sciatic nerve, which then go down into the leg, and that's where that phrase comes from. We'll go over some tests for it, but what happens is it's interesting because people sometimes just come in with calf pain, or they come in with a weak toe, and you try to convince them it's coming from the back, and they have no back pain whatsoever, and that's not uncommon. People that have a herniated disc can have just radicular pain and not have any back pain whatsoever, and people look at you cross-eyed when you tell them, you know, you might be getting pain from your back. I do a lot of knee surgery, and I see people that come in with anterior knee pain. Everybody's got them scheduled for an arthroscope, but all the studies are negative. It could be femoral nerve pain or L3, L4 pain coming from a disc herniation in the back. So you have to be careful about lumping everything in the sciatic or a nerve pain. It can happen, but you need the appropriate workup. The facet joints, as we explained, are really articular cartilage. They are joints where the vertebral bodies join. So these joints are composed of articular cartilage. So in our body, whenever you have joints, they are, for the most part, covered with articular cartilage. And what articular cartilage is, whether it's in the knee, the hip, the neck, is the smooth, somewhat compressible surface which allows the joints to move normally. The best way to explain it is when you take apart the drumstick of a turkey and you look at that nice white glistening surface on top of the drumstick, that's really articular cartilage. If you take a knife and dig into it, you've created a chondral defect, of course, and you have the subchondral bone underneath it. And all arthritis is when you lose the articular surface, when you lose the nice glistening surface and you have the raw bone apparent. That's what arthritis is in general. It's a mistake to think that we all get arthritis as we get older. That's not true. Osteoarthritis is a disease. It's been referred to as degenerative arthritis, which is a misnomer. We may get arthritis as we get older, but it's not due simply to getting older. We have an underlying disease process. And the disease process known as osteoarthritis is interesting because it's a disease of unknown etiology. We know it affects the knees, the tips of the fingers, and the back. So when I see patients come into my office who have arthritis of the knee, and it looks to be typical osteoarthritis with spur formation, the first thing you do is when they're talking to you, you shake their hand, you look at the tips of their fingers to see if they have nodules. The tips of the fingers, the distal interphalangeal joints, get nodules, and that's they're called Herbert's nose, but basically they're osteophytes that form from the distal interphalangeal joint. Those same osteophytes can form in the foramina at the articular surfaces, and these lead to spurs. And if they get really bad, the spurs can form what's called the generic lumbar spinal stenosis, where the canal is narrowed because you've got these spurs digging in, and spurs take a while to occur. So lumbar spinal stenosis, and we'll go over that, really comes from encroachment of the spinal canal from a osteoarthritic process, not necessarily a degenerative process. Not all of us get arthritis, But if we do have arthritis, there's a strong familial tendency, and when people come in, and they come into me for their knees, and I ask them, do you have any, sisters, brothers, mom, dad, that have arthritis, it's not unusual that they'll say that. It's an inherited disease of unknown etiology. That's osteoarthritis. There are a million other arthritises, psoriatic arthritis. People think psoriasis is a skin disease. It really isn't. It's a cutaneous manifestation of an underlying, probably autoimmune or rheumatic disorder. But people come in and say, I have psoriasis. When I see people with psoriasis, they come in, you can see the patches on their skin, on their knees and their elbow. They come in, they have back pain. Yeah, I have back pain. Why? Because they have spurs from the psoriatic arthritis in the back. But they're not usually aware of that because they think psoriasis is a skin disease. These spurs can irritate the nerves. I know we have plaintiff attorneys here, but if for any defense people that may be watching this, if you're paying for these facet joint injections, you're actually paying for arthritis treatment. Because if the facet joints are involved with arthritis, and then many people will do injections into the facet joints. But in reality, you're treating arthritis. Now, again, we're going to probably get into this a little later about the aggravation or exacerbation of underlying arthritis is another concern. But actually, facet joint injections are treating the arthritis as opposed to treating a herniated disc or nerve root impingement or something like that. But a lot of people, a lot of patients who are suspected of having the pain generator coming from the facet joints, they get the facet joint injections and they're done into the articular joints. And by the way, all joints need lubrication. So the body actually has what we call synovial fluid. So synovial fluid is actually the lubricating fluid in all your joints. And even if it's a small joint, you have synovial fluid in it. Synovial fluid is basically the motor oil of your body. So if you have an engine and you can't run an engine without oil. If you do, it's going to seize up. So it's very important to have lubrication of any joint. So when we went ahead to get artificial joints, we had to get a self-lubricating joint, and that's why artificial joints that work are metal on high-density polyethylene, because you can't have two similar surfaces articulate. There are ceramic hips and ceramic knees, to divert a little bit here, but the ceramic hips, not knees, but ceramic hips, actually cause squeaking. It would be like rubbing two ceramic tiles on one another, and a lot of people had ceramic hips put in because of the durability, and then wound up with a squeaking hip, which used to drive people crazy. So it becomes a real problem when you go ahead and and you have articulating surfaces that are the same. In the body, they should be different. That's why metal on plastic works so well. But again, synovial fluid is the lubrication fluid, and synovial fluid is found in all the joints. Lumbar spinal stenosis, as we measured, I've seen the aggravation case come up in trauma and workers' comp, of course, and again, we'll get into that somewhat at the end. But basically, lumbar spinal stenosis is a condition which has developed over many, many years. And what it leads to is to compression in the spinal canal due to multiple spurring at the facet joints. And it may come from degenerative disc disease that we'll talk about as well, where actually you have disc bulging from the disc coming, the vertebral bodies coming closer together. But anytime you see lumbar spinal stenosis, that's a condition that's taken years to develop. There are problems with the surgery. You would think, well, if you have all this compression, if you just go in there and do a wide decompression, but that doesn't always work. So as in most cases, the decision to do or not to do back surgery is very controversial. We're not going to clear that up in an hour today for sure. But some people do believe that the decompression can be done. It's rather extensive surgery because you have to remove basically the lamina and then do a fusion. So it's not a simple procedure when you're treating lumbar spinal stenosis, whether it's related to your case or not. But if it is related to your case and surgery is done, it's extensive surgery and may not work out that well. The spine muscles are, this is famous Frank Knitter. Frank Knitter was a doctor who was an artist before the days of digital photography and all that, and he was famous. And I always remember in medical school that the artists considered him a doctor, and the doctors considered him an artist. You know, he never got the respect that he deserved. But he was primarily responsible for doing these drawings intimately, because as a physician, when he would do cadavers, and then he would have all the drawings. So as you can see, the back muscles are rather extensive. The only reason I put this up is people kind of lump together sprains and strains. And they're two different things. Muscles are strained. Ligaments are sprained. So if you say someone has a lumbar strain, we see these things are written up all the time. I mean, in theory, if you say a lumbar strain, that means that all the muscles of the lumbar spine are either stretched or torn. If you actually do have a muscle injury, in the past, it was always felt that, oh, maybe, you know, it's just basically a historical diagnosis. But, you know, in theory, that you could do an MRI, and if the muscle was torn enough, it would bleed, and you would show it up as a discontinuity. We know that now with hamstring injuries. We do MRI testing, athletes that tear their hamstring. You get an MRI, and it'll show a muscle tear. So if you're trying to work up a case and people are concerned truly about muscle tearing or muscle injury, then what you would do is get a radiologist and get a radiologist to do an MRI and look for any muscle edema or any muscle tearing or hematoma in the muscle that might give it an acute indication of a soft tissue injury. You know, soft tissue, the attorneys here are going to talk about soft tissue injuries, working them up. Soft tissue injuries are always a matter of concern in terms of do they really exist or not, but there's no question a soft tissue injury that's severe enough can be determined by an MRI, especially if you're looking for it. And again, muscle damage may be apparent and a muscle is strained. The ligaments, this is just the cervical spine, but ligaments, so we're going to agree that ligaments are sprained and muscles are strained. Ligaments attach bone to bone. And that's the definition of a ligament. And they give stability. So you have many ligaments. You have your anterior longitudinal ligament, which attaches your vertebral bodies anteriorly. You don't see it that well, but the posterior longitudinal ligament attaches posteriorly. So when you're going into the disc space, this is an area that you have to actually cut through the ligaments. You have interspinous ligaments. The body is trying to puts all these ligaments in to basically give stability to the entire spine. So if you have an injury where you have a cervical sprain or a lumbar sprain, there may be significant tearing of these ligaments. So again, if you're working up your case and you want to relate it to the particular trauma, then you can go ahead and get an MRI, have the radiologist or your orthopedic surgeon or neurosurgeon, whoever you like, look particularly for any edema, hemorrhage, any disruption of the ligaments. Ligament injury is much more common in the cervical spine from the hyperextension. In the old days, before you had headrests that came up behind your occiput, the flexion and extension of your cervical spine would cause the injury. What can happen is actually it's very hard to flex down enough to tear ligaments, because when your head flexes, your chin, your mandible, hits your sternum. And what happens is then there's an extension of your neck, and that hyperextension is what does the damage, either fracturing the spine or tearing the ligaments, i.e. when you hang somebody on purpose, you tie a submental knot and the head goes into extension. It's what's called a hangman's fracture, which is C2, C3, where the vertebral bodies actually cut the spinal cord, they cut respiration, and that's how you die from a hanging. You're not supposed to suffocate, but what happens is the C2, C3 hangman's fracture transects the spinal cord and you stop breathing, and that's how hanging is supposed to kill you in a properly done way. But it's extension of your neck as opposed to hyperflexion. You don't see in the Hang 'em High Clint Eastwood movie, you don't see anybody going like that. They hyperextend. So that's how hanging occurs, and that's how these injuries occur in the car. The car injury, it's very important that you wear your shoulder harness, because the shoulder harness prevents your body from coming up and your neck riding over the headrest. So in properly designed the headrest has to be high enough to prevent your head from hyperextending, and that's how the injuries occur. So if you're sitting, I remember my old cars in the 70s, they had headrests that actually went up just a little bit and actually provided a fulcrum for your head to increase the injury in a car accident by extending over it, because we only had lap belts. So a lap belt is not enough. You need a shoulder harness to keep your chest and thorax in place so you don't ride up and have the ability to hyperextend and cause a cervical injury. Let's beat to death the discs a little bit, because this seems to be a fair amount of concern. The chiropractors probably did us a disfavor by calling what's called a slip disc. Because when you think of a slip disc, you think of like a checker that moves in and out. And it's the furthest thing from the truth. The disc is actually composed of two materials. It's composed of the outside, which is called the annulus fibrosus, which is like the bark of a tree. And the inside is called the nucleus pulposus. And people said it's like crab meat, but it's not really like crab meat. The best way to describe it is normal nucleus pulposus, like a nice couple of wads of chewing gum that you have. It has that consistency. And let's see if we have the next slide here. This will be better. So what happens is you have the nucleus pulposus, which sits between the vertebral bodies. And that actually is a cushion. And then the annulus, the bark of the tree, is like the restraint to that. And the reason being, and I have a model here which I shouldn't have duct taped, but what happens is if you can imagine, if I didn't have this duct tape right here, if we had a hole in it here, if I just put a wad of chewing gum, a big wad of chewing gum between these two cups, and I did not have the duct tape, which represents the annulus fibrosus, if I push these two cups closer together, the chewing gum is going to extrude outside of the confines of the cups, which loses any cushioning ability whatsoever. So how are you going to stop that from happening? Well, the body puts the annulus fibrosus in. The annulus fibrosus is the restraint to the nucleus pulposus coming out, and by restraining it, it creates the cushioning effect, and it still retains motion. So what happens, and we'll talk about degenerative disc disease, the nucleus pulposus, this chewing gum, is about 80% water. So in the course of life, in certain, not everybody, but we kind of dry out as we get older. So what happens is the disc will dry out and lose that cushioning ability. And then what happens is the vertebral bodies come closer together. And when the vertebral bodies come closer together, it doesn't happen on the model here, but the duct tape has to go somewhere. So if I have this out straight like that, you can see the duct tape is nice and taut. But if I go and push the vertebral bodies closer together, in this model, the duct tape goes inward. But in the body, what happens is circumferentially, the duct tape will bulge outward. And that's what we call disc bulging. So disc bulging is considered to be non-traumatic, degenerative in nature, not causing symptomatology, but represents circumferential bulging outward of the annulus fibrosus in response to loss of disc material. It does not come from increased pressure. How else could we get the annulus to bulge out circumferentially? Well, I guess we could put fluid in or inject fluid in to increase the pressure in the disc space to bulge it outward. That just doesn't occur. So disc bulging is a real problem when it comes to trying to define it, because people have said a disc bulge is traumatic in nature. It represents an isolated thing. I'll show you why I don't feel that's really the case. But it's a very simple concept. You've got your nuclear material held in place by the annulus fibrosus. Years ago, I used this analogy when I did these talks 15 years ago, and now I see them, and I'm convinced they copied from my presentations. Convinced. because I think I was the first one to have the jelly donut. Probably not, but I think actually this was my slide from giving these talks maybe 15 years ago. And this probably represents the best indication of really what a herniated disc is, because the donut shell is the annulus fibrosus and the jelly is the nucleus pulposus. And when the kid squeezes down on the jelly, he pushes the jelly out probably from the weak spot in the annulus where the jelly was injected to begin with. So this would be a weak spot in the annulus fibrosus, and I guess we can consider this to be a lateral disc herniation. But it's not causing any symptomatology yet. There are no nerve roots here that it's irritating, but when it drops on the kid's shirt, then it's going to cause problems, so they don't become symptomatic. The other thing is that if you think about it, if you're going to have a flexion force, if you look at your vertebral bodies, and what happens is, again, if suppose this is a lateral view of your spine, and you bend forward, your vertebral bodies compress anteriorly, what does it do? It pushes the jelly out backwards or to the side. So that's why a flexion injury causes a posterior disc herniation or a lateral disc herniation, because most injuries in the lumbar spine are flexion. You have very little extension of the lumbar spine. In theory, if you had hyperextension of the lumbar spine, you could push the disc material out front, but there isn't a lot out there to irritate. There probably are anterior disc herniations, but they aren't as frequent because it's much harder to extend the lumbar spine. You have a tremendous amount of flexion of the lumbar spine, and that's why you get a posterior or posterolateral disc herniation. And this is the schematic of it. So when you have the disc herniation, you have the nuclear material which comes out, and then of course you have your nerve roots which come out, and the nerve root can get encroached by the nuclear material, and that's what we would call a radiculopathy, or irritation of the nerve root by the nuclear material. Let's see what I got here. This is a post-mortem specimen, obviously, of what a disc herniation looks like, and all this material comes out from the interior of the intervertebral space, and it just kind of sits there pressing on the spinal cord. When I did laminectomies and disc excisions, it was gratifying once you got down there, because you just see this big, again, wasn't really crab meat. If it was an acute disc herniation of like a piece of chewing gum that was just sitting there, and you would just go in there and just pluck it out carefully, and it would come out actually a lot of times in just one piece. And it was a great operation. People talk about, oh, back surgery, it's horrible, and no one gets better and all that. But if you choose your back surgery correctly, when I did back surgery, I always did it for radiculopathy. I never did it for back pain. I said, if you got back pain, I'm not going to get your back pain better. But if you had a radiculopathy, if you had sciatic pain in the leg, if you had nerve root impingement that correlated with that, and you had a myelogram or MRI that correlated with that area, the success rate was tremendous in someone, of course, who wanted to get better. So it was always a good operation. But when I did laminectomies, I never did them for back pain. I always did them for leg pain. And I always thought I got good results. I always thought that, but you have to choose, and in most surgery, you have to be careful who you choose to have the surgery. If you choose someone who doesn't want to get better or don't have the indications for surgery, it's not surprising that they don't get better. But it was very gratifying to go in there and just take out this little bit of material, because they would get immediate relief, for the most part, of their sciatica. I'm saying sciatica, but the same thing applies to the cervical spine and the neck. But you get pain in the arm. We don't have enough time. We'll probably do some clinical exam to go over that. But in the arm, you have the same radiculopathy. And these are people, if you herniate a cervical disc, then you have pain going down the arm, and it can go into the fingers. In the hand, many times it gets confused with carpal tunnel syndrome or brachial plexopathy. So there are ways of determining a radiculopathy. We don't have time to do today. EMG and nerve conduction studies can sometimes differentiate where the radiculopathy is, and that goes for the upper and lower extremities. But you have to again be sure. But if everything correlates, if you have a neck injury, you have someone with a disc herniation, disc protrusion, as we'll go over, someone who has nerve root irritation, a positive EMG, perhaps neurologic findings on physical examination, those people actually should do well with surgery if conservative care fails to help them. Disc definitions, let's go over this. A normal disc, again, I felt that the bulge was circumferential, bulging of the annulus due to degeneration. The disc protrusion, I'll show you, is sometimes read by radiologists, in my opinion, as a disc bulge, and that's where all the problems come from. But it really should probably be referred to as an isolated bulging of the annulus, should actually be referred to as a protrusion. A protrusion to me would be a traumatic event. Disc bulging circumferential around the whole disc would be, to me, a degenerative process. An extrusion is interesting, and I have more slides. An extrusion means that the material, the nuclear material, is no longer contiguous. There's a separate blotch of it, let's put it that way, outside of the inner space. The annular tears we'll talk about, because that can be a source of pain. And again, the facet arthropathy we talked about is arthritis pain. So this is a better slide. You have you're looking down, you have your nuclear material, you have your bark of the tree. And what you're going to have over here, and I put in bulge here only because it's probably wrong, it should be a protrusion where now the nuclear material is starting to come out through the bark of the tree, but hasn't progressed outside of the confines of the disc space. But if on the MRI, you're going to see this material, and it has to come out through an annular tear. So the fact of the matter is that if you have herniation of disc material, you have to have an annular tear. And what's important to remember is that this third of the annulus fibrosis has nerve endings, sensory nerve endings, and can be a source of pain. So it's another complicating factor. So people will say, well, you don't have a herniated disc from the accident. You don't. The pain is facetious. You're making it up. But on the MRI now that you can see, you have an annular tear. The annular tear itself could be a source of pain. Anything with pain fibers can hurt. So I think now we have to consider that an annular tear could be the source of the pain. It would be just like ripping anything that had sensory fibers. And annular tears are visible on discograms, on myelograms, and on MRIs. Now, a disc herniation, this is commonly what we see, is where the disc material is starting to come out, and it's a very thin, there may be even a very thin layer of the remaining annulus, or the annulus may have busted completely, and now the nuclear material is sitting on the nerve root. And then the worst case is you have an extruded disc or a free fragment, and you can see, it's harder to see here, but this pink stuff is now a separate piece of the chewing gum which is broken off the continuous material that goes into the disc space and is broken off. And this is of a surgical import, because when you go in there and everybody's doing microdiscectomies and all this kind of small surgery, and that's fine, that's a whole nother topic. But when you go in, you have to be absolutely sure that you might go in surgically through an isolated laminotomy or laminectomy, and you go in and you curette out and remove this material here. You have to be sure you go in, and this can be in the foramina over here. You have to go in and make sure you're not missing an extruded fragment of disc. And that's actually the cause of the symptomatology, because then you're going to do your surgery, the person isn't going to get any better. You're going to get an MRI or a study down the road and find there's remaining disc material. That is disc material that was never found from the original trauma. So it's very important as a surgeon you make sure you get out and check all the nerve roots to make sure you're not leaving a piece of disc material in that's going to cause problems after your surgery. The disc material has to go out through a rent in the annulus. So by definition, if you have a herniated disc, you have to have an annular tear. Has to be. The disc herniation comes out, and this is what it looks like on the MRI. It's material, and you normally don't see it this nicely, but you can see a big piece of material just sitting out, impinging on the nerve roots. So the MRI has helped us tremendously in making the diagnoses. And again, the annular tear is the outside 1/3 of the annular ring, highly innervated with pain fibers. So, you know, and I actually think probably and we've all done this, when we make a stupid move, you just bend over very slightly, you don't really do anything, and you get a pain in your back, and it hurts a lot, and you can't get in and out of a car. I always noticed that when you had the thing, you just couldn't get into a car easily. It wouldn't be surprising if probably, and everybody kind of lumps it as a lumbar sprain strain, but it's hard to believe just that little type of trauma could tear a ligament or tear a muscle. It's probably an annular tear. It wouldn't surprise me if you had that little injury and then you go ahead and had an MRI, which you can't get anymore because no one approves them anymore. But if you went ahead and had an MRI, it wouldn't surprise me if you might have a little annular tear, which is the source of the pain. Because it's real pain, and it really stops you from doing things for a while. And we know the annulus is so in your workup, when you have a trauma case and you're doing a little bit of a workup, consider the annular tear as a source of the pain, because definitely it could be related to trauma. The problem you have with an annular tear in terms of working up from a plaintiff standpoint is that it's like 1/3 of everybody, the commonly quoted statistics, 1/3 of everybody over the age of 40 has a herniated disc. If we just did MRIs of the people in this room, we would find a herniated disc. 1/3 of people have a rotator cuff tear. So the joke is that if you're going to be in a car accident, complain of both shoulders and your neck and low back hurting, you're going to wind up with 4 MRIs. In all likelihood, one of them is going to be positive because 1/3 of these studies are positive. So just don't complain of a little bit. Complain of a lot. If you get 4 MRIs of your neck, low back, and both shoulders, in all likelihood, it's going to show a rotator cuff tear or disc. The problem we have as clinicians is trying to decide what's the pain generator, of course. But so just because as an attorney, a plaintiff attorney, defense attorney, you see an MRI that shows a disc herniation or a rotator cuff tear, you're going to find people that believe that that was pre-existing, not related to the accident. You're going to have to work that up as such because of the accepted statistics that 1/3 over a certain age have not just disc herniation, bulging or protrusions, actual disc herniations, actual rotator cuff tears. Degenerative disc disease, quickly. We'll leave 5 minutes, I think, for the physical exam, so we'll just keep going here. Degenerative disc disease is very simple, and it probably shouldn't be called degenerative because not all of us get it, but the discs are 80% water. We know cigarette smokers, cigarette smoking is just not good for you for the most part, except to keep you thin. And the nicotine in the cigarette smoke is a vasoconstrictor, and the theory is that anything that reduces blood supply is bad for you. There are no blood supplies within the disc material. The disc material is kept healthy by the blood supply on the outside, in the vertebral bodies and in the annulus. And the theory is that the cigarette smokers, the nicotine, you have a decreased blood supply in the back, and that leads to degeneration and loss of the water content. And what happens is then these spaces become closer together, and if the spaces become closer together, what happens is in the foramina become closed down, and you may get instability or degeneration causing nerve root impingement just from simple what's called degenerative disc disease. That's a chronic condition. The problem with the cigarette smokers it's a general accepted fact that no one operates on a back if you're smoking cigarettes, because back surgery in cigarette smoking, they always have back pain. So if you have a case where you have a cigarette smoker and you have a case where you're trying to work up back pain from trauma, it's going to be very difficult to isolate what's due to the trauma versus due to cigarette smoking, because we all know that smokers have back pain, and that orthopedic surgeons or neurosurgeons that fuse backs pretty much nowadays will not even consider fusing a back until someone stops smoking, which is very, very difficult to do. It's very hard to stop smoking. But there's such a high indication, it's such a high incidence of back pain in smokers. A myelogram does not show a disc herniation. A myelogram, and they're not done that frequently now, but they are done with CAT scans now, in which dye is put into the spinal canal,
And if there's a disc herniation or a tumor or whatever pressing down, then it shows the representation of where the dent is. But it's a mistake to think that when they say, oh, the myelogram shows a herniated disc. An MRI shows a herniated disc because an MRI shows soft tissue. But actually the correct terminology, a myelogram shows an indication of what may be a herniated disc. It could be impression of a spur on the thecal sac. It could be, hope not a tumor. But a myelogram is an older study. It's still a very good study, but doesn't show soft tissue. It just shows where the soft tissue or bone is impinging on the spinal canal. I know it's a matter of terminology, but it indirectly shows abnormalities. The MRI, however, that shows soft tissue will show a tumor or herniated disc. The CAT scan and discogram, these discograms are controversial. There are people that believe in them and people don't. Basically, it was, if you can isolate the pain generator, stick a needle into a disc space, you force fluid in to a certain amount of pressure. If you get reproduction of the pain, it signifies that area. There's a lot of controversy over it. We're not going to clear it up today. People say, well, if you inject enough pressure into the disc space, anything's going to hurt you. It's probably true. So just because you have a discogram, people do discograms, doesn't necessarily mean that's the pain generator. Otherwise, that would be too easy. But discograms are around. I'm sure in proper hands they're useful. But if you do get, if as an attorney you are using people that do discograms routinely, you have to be prepared for if it's a defense doctor coming in and criticizing that or criticizing the person as discograms not being scientific. So you have to be aware of that. Very quickly, the spinal cord is just all the nerves that come down. I was asked to discuss it, but spinal cord injuries, I put a very complicated slide which you can refer to. Spinal cord injuries obviously are severe. A complete spinal cord injury, everything below the level isn't working. A partial, some things are working. That's a clinical diagnosis. It is an emergency. If you have a spinal cord injury, it's obviously an emergency. Most of the times the spinal cord is not transected. It is simply crushed by the vertebral bodies. You can tell the levels by the clinical findings, and I put that in the slides for you. The treatment of spinal cord injury, when you see the football players being carted off, they're trying, this is a neck injury, they're trying to prevent more damage. There are some indications that if you give cortisone, dexamethasone, methylprednisolone, within 8 hours it may reduce the swelling. What's interesting is that there can be a side effect of prednisolone or prednisone. High doses of prednisone can cause avascular necrosis in people, leading to hip problems and knee problems and shoulder problems. So it's not entirely benign to give a huge loading dose of prednisone, but there are people that believe in it, people that don't. And surgery, obviously, it's a major surgery. If you have a spinal, if you have a fracture, it's a lot of hardware that goes in bone grafting to fix that. Recurrent disc herniation, again a slide, this comes up in medical legal terms. If you take out a disc herniation and then a period of time goes by where someone is asymptomatic, and then you have another injury and you have similar symptomatology at that level, and you can isolate it to that level on that side, that can qualify as a recurrent disc herniation. It was felt that it just might be a recurrent disc herniation would be at the level, say you have an L4, L5 disc herniation on the left side, and now you have it on the right side. There was some controversy that maybe that considered to be a recurrent disc herniation. Actually, it should be at the same level on the same side. So I put this slide in, this Medscape article on your, you can view that, gives a good article because that comes up all the time in trauma. People that have surgery, they have a subsequent accident, they get an MRI, they've got a disc herniation. Is it referable to the first accident? Is it referable to the second accident? We're going to talk about clinical exams, and we're going to just do a few things, but basically you can determine sometimes, this was done when people did physical exams before we had to go into a clinical exam of somebody. And then again, the aggravation, and we'll finish up with that before we do, these are medical legal terms. We'll probably talk about this a little later if you ask me about it. But all I can say is from a doctor's standpoint, there are no medical articles, there are no statistical references that medically determine whether something has been aggravated or exacerbated. If you look up aggravation of degenerative disc disease, exacerbation of degenerative, in my business, I see knee arthritis all the time. People bump their knee, they need a knee replacement. A judge in workers' comp picks it up as an aggravation and is accepted as workers' comp. All I can say is that scientifically, if it was in a civil case and you had to scientifically prove this, if you were worried about a Daubert or a ruling or a Frye ruling, there is no scientific or statistical evidence that I know of in the medical literature that supports this from a scientific standpoint, if that matters. It's basically subjective. It's basically someone saying, I hurt more now after the accident than I did before. That's what an aggravation or an exacerbation. I don't argue that people with a degenerative condition can have pain, that if you have a degenerative condition and you're at work and you're on your feet a lot, you're going to hurt more. That's just common sense. It would be like you have a cavity in your mouth. If you kept chewing on the cavity, you're going to have a lot of pain in your teeth, but you stop chewing on it, you're not going to have pain. But after you're done chewing on it, the cavity is no bigger. So my point would be is that if there's no anatomic change in the area you're looking at, then I think the aggravation or exacerbation theory would be hard to prove scientifically that there is no more distortion of the anatomy after trauma than one before. That's just an opinion, and obviously you get a bunch of different opinions from different doctors. That concludes this talk so far. I think we would like to go ahead and just do a very basic, a few minutes of the clinical exam. Thank you for your time and attention. On our model here, we're going to just show some, very basic, some tests that we do, and this is what's called a clinical correlation. Because again, as we talked about, we get so many MRIs and tests and things, and we try to find is there clinical correlation. So if we have somebody that comes in with a lower back injury, we don't have time to do the neck and upper extremity, but a lot reflects from that. If you look at the lower back, I generally would ask somebody, you want to point to me, where your lower back hurts you? Okay? And we generally do what's called a range of motion. Now, there are two different types of range of motion. There's active range of motion and passive range of motion. Passive range of motion would be where I actually force someone to move, and I just don't do that anymore because, first of all, people come back and complain out, you hurt me more than ever, and I don't want to be in that position. So what we do is ask people to do an active range of motion. So I would ask Brad here, I'm going to test your flexion. So stand up straight with your legs and bend forward as far as you can. And he's very flexible, you can see. And you can actually have a protractor and do range of motion with a protractor. And he has excellent forward flexion. Everybody has different flexion of their back. And I'll have you stand up. And then you have to the spine, you bend to your left, and then bend to your right. And then you record those motions, and then you have hyperextension, lean back. You can see hyperextension is very limited in the back, and that's why we don't get hyperextension injuries that much in normal people. We do get them, of course, in gymnasts. We didn't mention spondylolysis or spondylolisthesis, but in gymnasts or people that do a lot of hyperextension like that, they actually can get stress fractures of the pars interarticularis between the vertebral bodies, and they wind up with slippage of the spine. That's, again, a whole nother hour. But people that have hyperextensible spines, like gymnasts, can often get spondylolisthesis and spondylolysis, by the way, which is considered to be trauma. If you have any cases where people have spondylolysis or spondylolisthesis, that can be reflective of trauma. It was felt to be maybe congenital in nature, but there's more and more indication that spondylolysis is traumatic in nature. And then, of course, there's rotation. There is some rotation in the lumbar spine, so you fix the pelvis. Brad, just twist to your right and twist to your left. And those motions are noted. Thank you. Now, in terms of muscle spasm, that's a very subjective thing, but what happens is muscle spasm is done to stop the spine from moving. You know, when you're hurt or anything happens, the muscles react by stopping motion. The muscles act as an internal splint. So why do you get muscle spasm? Because the muscles are trying to prevent that irritated area from moving. So if you fracture your leg, it's all deformed because the muscles contract spontaneously with a fractured femur or in a fractured tibia to stop the ends of the bones from moving, from destroying the nerves and blood. So it's a protective, muscle spasm is protective. And the same thing in the lower back. You get muscle spasm because the body is trying to stop itself from moving, from irritating the damaged area and allowing it to heal. So you can palpate the muscle spasm very simply. You also want to check out the sacroiliac joints here. And it's just part of the exam. Now there's another test. I'll have you face that way, Brad. It's called the Trendelenburg test to measure if there's any weakness in the hip muscles. Normally, just stand on your left leg. And when Brad's got good muscles, so when you stand on one leg, you compensate with your hip muscles to keep your pelvis level. If you stand on one leg and now tilt to your right side, that's a positive test that indicates weakness of the hip muscles. That's a Trendelenburg test. Great. You're doing great. I'll have you sit down here. We're almost done. One thing that you have to be sure of, and I see this all the time in my practice because of radicular pain, people think the hip joint is back here. It's not. The hip joint is your groin. So people that have arthritis of the hip have groin pain. And so the way that you test that is, I'm just going to relax your leg. This is beyond the back exam, but when I move your leg internally rotated and externally rotated, people that have an arthritic hip will complain of pain in the groin or sometimes pain radiating down the front of the leg. Many times I see people with knee pain and they're told they need a knee replacement, and no one ever does this simple. So I just routinely, when I see people for their back or their knee, I always rotate their hips, because what will happen is if you have arthritis of the hip, you either have groin pain or the hip will not internally rotate. So if you lack internal rotation like that, that's a hip problem, but not a lot of people know that. Back to the back examination, the reflex testing is objective. What I mean is that people cannot stop the reflexes from happening. And the quadriceps reflex is controlled usually by the L4, it is controlled by the L4 nerve root, which usually exits between, the nerve roots usually are involved below the vertebral levels. Like when you have an L3, L4 disc herniation, that's the L4 nerve root. When you have an L5, S1 disc herniation, it's the S1 nerve root. So, and I should do it with a reflex hammer, but we'll see if we're any good here. Oh, and it works. You're hyped. And I see, you can't try to stop me from doing that. Wait, no, tense up, that's right. You can't do it. So reflex testing is absolutely objective. Now, you have good reflexes, so you can't stop. So if I tapped you like that, and I go over to the other side here, same thing. But if I did that, and there was no reflex on that side, then I'm thinking, well, maybe that's an L4 nerve root if you had pain coming down your left leg. So the knee reflexes, again, no one looks at patients anymore. Everybody just orders tests. But the knee reflexes are the L3, L4 interspace, L4 nerve root. You can go down here, the Achilles. Most disc herniations are at L5, S1. And that's good because the Achilles reflex, this is hard to do. You should have someone lying on their stomach with their foot dangling, but you can tap in the back over the Achilles tendon and the foot will plantar flex. So it'll come down. And that's the S1 nerve root. And I'm not going to have you take your shoes off because I want to get done, but the last test that you can do is an L4, L5 disc herniation, which is the next most common area, is actually your big toe extensor. And if there's motor nerve involvement, I'll just have you hold your foot up like that, and I'm going to push it down. You can't push it down. But someone that has a motor involvement at L4, L5, or the L5 nerve root, they can't help it. You just push their foot right down. And those are the basic clinical tests that you can do in terms of a quick exam. You can do sensory testing, where you can just simply take cotton. People that have a dermatome involvement of a nerve root will have numbness or tingling in a specific dermatome. If people have what's called stocking glove, well, doctor, my entire leg is numb, well, that could be a sign of symptom magnification, and that's going to be talked about by our attorney. So that, in a nutshell, is a very basic clinical examination. There's a lot more that you should do, but it's important, I think, to do a real good physical examination when you see somebody, see if there's clinical correlation, and then combine that with judicious clinical judgment and a review of all the laboratory and radiographic studies. We're going to take a short break right now, and then we'll